Now we've got a new panel of experts here, and it's going to be a great discussion. Shafia Monroe is a midwife, doula, trainer, and master in public health. Really cool. I can't wait to start talking with her. She is the president of Shafia Monroe Consulting, Birthing Change, which provides training to health professionals to improve cultural competence and birth outcomes. And Joia Crear-Perry is a physician and the president and founder of another great organization, the National Birth Equity Collaborative, an organization focused on reproductive health that addresses racial and social inequities. We've been talking a lot about that today. And finally, Wanda Barfield is the director of the Division of Reproductive Health at the Centers for Disease Control and Prevention. The CDC's current Hear Her campaign seeks to encourage partners, family, or providers to really listen to the pregnant women in their lives. And the aim is to provide communication and reduce pregnancy risk. A big welcome to all of you. Dr. Barfield, we haven't met before and talked, and I want to have all of you back lots of times. But one of the things I found interesting in just reading this is it just came clear to me that the healthcare system has this issue of rigidity and not hearing people, and particularly in the maternal area. And I asked, Representative Jamie Herrera Butler about this and your work there. What do we need to do to build a system that that listens to people and where people feel empowered to actually say how they feel? I mean, you would think it would be baked in already, but just reading your material, I know it's not.
Yeah, I think that what you bring up is so important. And we heard earlier about the importance of hearing from women, that they know their own bodies, they know themselves. And when there's something that isn't just quite right, we need to listen. And so the purpose of the Hear Her campaign is really an opportunity to share these messages. We have vignettes of women who have experienced pregnancy-related complications. And it's really an opportunity to talk about how we can support women in terms of their close family members, as well as health providers and others. We all really have an important role to play.
I really appreciate that. Shafia, I guess I would love you to kind of help our audience understand what culturally informed birthing traditions are that we are not baking into our healthcare system that we ought to begin thinking about. This is an area that you're living this experience. I think it's really fascinating, but I want to have our audience understand why it's so important and what are we not getting right. I mean, because I just want to tell our audience, we're not getting a lot right because there's a crisis in this country. So what do you think would be part of the element of improving both infant birth outcomes and reducing maternal mortality?
Well, thank you for that question. So glad to be here today. And I want to start by saying that you're absolutely right. We're not getting things right. And it's really a travesty at this point in time that we're still having this conversation, having been involved in this work for actually 40 years. So I'm a pioneer here, not giving an age. But I want to say that we have to understand that the United States of America has different cultures. We are not a melting pot. We are a pot full of stews of different things in this pot. And there's different cultures, different races, different beliefs. And the medical model is only taught one type of care for one particular group of people. That does not work for African Americans or Native Americans or Asians or newly arrived people to this country. And so it's important we look at each family and each culture as an individual and take the time to understand how they understand the information called health literacy. How do we deliver the information to them so they can take the information back? We have so many examples of families being given prescription, the directions, and not understanding, and actually going home and actually dying or getting very ill. So if English is not everyone's first language, people hug, people don't hug. There's so many things we have to take into account. And so that's the work that I do is work with medical providers and doulas how to be culturally competent. And there are 5 different levels of cultural competency: health literacy, appropriate action, advocacy, direct care. And so it takes time to learn, but we have to be committed to it, and that will make a difference. And we talk about equity as one of the themes here, and access and prevention. Cultural competency actually works for that. And the other piece is actually using midwives, because most cultures around the world historically use midwives first, where these women often lived in the community. They're already culturally competent. They understand the language of the people in the ways so they can get the information of good, healthy care to these families. which is why I have to lead up that we're having that Alabama Black Midwives Conference in
Right.
Alabama to deal with the rural deficit of not having enough care in these rural communities.
Before I jump to Joia, I want to just go one further step, Shafia. With what Wanda Barfield just shared with us, about, not having a system right now that is the aperture is open to hearing from women where they're at. Are you aware? I mean, I'm always interested in seeing whether systems have evolved or changed for the better. And given your long experience in this, have you found places or models or anywhere in this country in your 40 years here that have begun to say, hey, this is what we need to do to hear? I mean, you've been out writing it. A woman's body heals after birth. It takes a long time in some cases to do that. That's part of hearing where people are at. And I'm just wondering if you've seen any system improve and evolve in the direction you think is healthy.
Well, I actually have seen, definitely, I want to mention the DC birth center in DC that is in an underserved area with high infertility rate, because they have employed African-American midwives and African-American doula teams, and they're using outreach. They've definitely changed the infertility rate much lower than it was prior. And we now know that having culturally competent doulas, which means that a person trained to provide emotional support to a pregnant family, particularly the pregnant women, is a bridge between the medical system and that family to help them get their needs met, but also help physicians sometimes or midwives to understand what the family needs. So they're that bridge. So having doulas for sure, and having community-based birth centers that are run by the people who represent the clients who come into the area. The other piece that works really quick is that we need to make sure that we continue making doulas available in every single state for Medicaid reimbursement. Can I add one more thing, please? I read the brief before I came on. We talked a lot about Medicaid reimbursement as one way to solve the problem. I absolutely understand that. But African Americans, we know that Medicaid does not solve the problem. The majority of Black women who are dying, having poor outcomes, are actually highly educated, degreed women who are suffering from maternal mortality. So Medicaid is helping low income, but we need a system that helps all Black families, regardless of the economic level, because studies show that it's not just about money. You can have a PhD and be just as much risk of having a death with your baby or yourself compared to a white woman without a high school diploma. So we have to go deeper than just Medicaid expansion.
Right. Well, thank you so much for that. Dr. Crear-Perry, I mean, I find this really cool that Dr. Barfield nominated you as one of America's leading Americans in during Black History Month. I just love the exchange from the two of you on Twitter, so first of all, congrats, that's really cool. But we're talking about serious things here, and I know that let me just put it this way. We know through COVID, we know since after the George Floyd, we know that this nation has divided. And when a pandemic hit, we're seeing things that were already underlying, which were very different health outcomes for different communities, and it shouldn't be that way. So there is this question of injustice in health and racism in the health system. And to a lot of people, racism is a big word. But, if you're going to undo it, you have to undo pieces of it structurally and change things. And I'm just wondering how, in the work you do, you address it so that you're able to get to a specificity and attraction in your work. Does that make sense?
Yes, it does. And thank you so much again. And I'm so honored to be here with Mama Shafia and Dr. Barfield. It's just amazing. So we have been doing this work at the National Birth Equity Collaborative for about 6 years, doing anti-racism trainings. And imagine 6 years ago when we first started, when we would say the word racism, it would make people very nervous. They would have an emotional response, because for so long, the idea of racism was something that bad people do, mean-spirited people do. We didn't talk about the fact there has been, for hundreds of years around the world, a belief in a hierarchy of human value based upon skin color. And that belief was then placed into policies and practices. So you see things like segregated hospitals that were legally segregated by law become still segregated even when the laws leave, because we still devalue people based upon skin color. So talking about this cultural belief and that some people are more important or some people are smarter, or even I was taught in medical school that there were 3 biological races: Mongoloid, Caucasoid, and Negroid. There's no biological basis of race. This was in the late 1990s. right? So I had to unlearn what I was taught by very smart people at my medical school, right? This was in textbooks for a long time. So this belief in a biological basis of race was never real. We don't have different kidneys. We don't have different lungs. We don't have different pelvis. I was even taught that there was a black pelvis shape, that black women have an android pelvis and white women have a gynecoid pelvis. All of that eugenics was codified into healthcare. So you see, when patients come in to see a practitioner, someone who looks like me, who trained in a place that said black women have different pelvises or different kidneys, they're going to treat them differently. That belief is still there, even when we stop talking about it. So I love learning about Mama Shafia years ago and working with her and understanding there's a lot of other ways that people have been experiencing birth. And around the world, we don't blame and shame people around their birth. We actually say, listen, we support your birth. We're here to support your birth. And that's what we haven't done in this country. We haven't seen birthing as something that all people should be able to do in a loving and kind environment, that they should be valued, they should be listened to, they should be heard. And we've really created a population control. We use that as our tool. As an OBGYN, that was operationalized as well. We would say who should have children and who shouldn't, and then we would create policies around that as well. So having that truth first, that honest historical truth about the history of how we ended grand midwifery, when we created the field of obstetrics and gynecology, and how we're here today, baked into the system, we can do better because the belief is killing all of us. White people in this country are also dying because we're not investing in Medicaid expansion. We're not investing in having access to paid leave and equal pay. So racism is killing all of us. So it's an opportunity for all of us to thrive if we undo this harm of a belief in a hierarchy of human value.
Joia, I just spoke to Representative Alma Adams. I mean, she's one of my favorites, and I really just love talking to her. She's optimistic that things are going in the right direction. I have to tell you, I get in the weeds so much on this, I can't often tell which way things are going. Are you optimistic on where we're going on these big issues you're dealing with?
I am so optimistic. I tell you what, I get the honor. Last summer, I got to march with the Movement for Black Lives, and there were people of all colors and all races and all religions there, because we understand around the world with the murder of George Floyd and Breonna Taylor that we can no longer have groups of people who are structurally disadvantaged, who are creating policies that say you don't belong, because it harms us all. So I'm so optimistic about what we're building together. Even being on this panel today, seeing kind of this combination of traditional birthing and the CDC on one panel. Who would have ever seen this as expertise? This is not something that we've done before.
Wanda Barfield, I want to just ask you like a science question here and about the public health infrastructure of the country. And I guess when I see numbers, in a society sort of change so dramatically, I mentioned this earlier of looking at the number of infant mortality or maternal mortality incidents, in 2007 versus 2014. So that was 7 years. Really dramatic change in the wrong direction. Not a big period of time. I don't have the data since then. I just know that it has not necessarily improved in a significant way. What happened in that era that, and is there, beyond yourself, did the CDC begin to freak out and say something is collapsing in our healthcare system when you see such a dramatic change? As I mentioned earlier, if we'd been looking at the Soviet Union or any other country, we'd be saying, wow, that society's in trouble. So I'd just like to know from a policy perspective, what happened, and do you think the measures we've talked about today are substantial enough to begin reversing those?
Yeah, so I think that there are some substantial things that have happened that haven't allowed us to move forward. First and foremost, in the United States, we have depended a lot on our advances in technology, but technology simply isn't enough. I'm a neonatologist by training, so I'm really acutely aware of the importance of the advances in medical science. However, we're really now starting to really understand that there's so much more to health than simply healthcare. And also, we really understand how important it is to improve the health of women and mothers in terms and birthing people in order to improve the health of infants and families. And so we're getting to that point now. For example, even in thinking about the work that we're doing with maternal mortality review committees, we understand that we need to bring the community into the dialogue and at the table in the discussions around maternal death, because we understand that social determinants of health, the factors within the environment and within the community may also contribute in terms of the relative disadvantage that people are facing toward the death of a birthing person. And we also know that these deaths can occur later after delivery and in the context, again, of not just the hospital. The other piece, too, is that we're in all of this discussion and dialogue, we're really talking about, the impacts of racism and discrimination and how it is impacting our health. And we know that women are being treated differently, particularly women of color, in terms of their health care, whether it's hospitals that are lower quality, or even the opportunity to speak about their concerns and not being heard. And I think what's also very important is understanding how the data can be utilized in order to really improve outcomes and processes. And CDC is working with so many of the partners at the federal level, at the state level, and at the community level, as well as in tribal areas, to really try to improve this data so that it better informs. We have community vital signs, and we're really trying to understand the context of which women are living and what has been their risk for death.
Before I jump to a question from the audience, Dr. Barfield, each health discussion that I end up getting the privilege to moderate has its own sort of nomenclature and language and terms, and so one of the areas that's so very important, in this discussion is postpartum, support, mental health. Now, if I were interviewing Senator Debbie Stabenow, who had been working a lot on, trying to get mental health support and facilities out there, it's a slightly different framing of that. But it raises the question whether or not there are resources and ways of looking from a policy perspective where we look at mental health and the deficits in that, right, in our healthcare system, whether we're weaving these worlds together well enough, and what your sense of that is.
I think that's really a very important issue in terms of looking at mental health as a very important aspect. And so even in, for example, thinking about the care of postpartum coverage, right? It's one thing to have the coverage, but really understanding what the content of coverage is going to be, particularly based on the needs of particular birthing people. And in that postpartum period, there would be an array of needs that could include, following up with regard to hypertension, mental health supports, and understanding some of the factors that contribute there, as well as factors that relate to issues around violence. So I think that it's going to be really important to think not only about the coverage, but what is the content and the quality of care that's being provided.
Oh, thank you.
And that is, I think, an important distinction between the U.S. and other parts of the world.
Oh, that's fascinating. So I've got a question for you from Danielle. Danielle?
Hi, my name is Danielle Blakeney. I'm an LPN lactation consultant and the owner of Milk and Melanin Lactation Services in New Haven, Connecticut. As an IBCLC of color, my passion is to provide breastfeeding services for families of color. So my question is, how do I go about receiving funding for those families who may not be able to afford my services?
Interesting question. Sharia, your thoughts? Shafia?
Well, we talk about policy. There should be a system within the public health system and the hospital that automatically provides services for breastfeeding. And congratulations and thank you. We know that breastfeeding saves lives for babies, full term and early. So your work is very important. There is a big movement to support breastfeeding. So I would definitely look at policy as we talk about this on this talk, wherever the policymakers are, that we add that to the Omnibus 2021 and all the other ones we have. In addition, unfortunately, I say unfortunately, is also looking for grant money, which I think is unfair when you're already a small business trying to make a big need. So I think we need to put that into it. Medicaid should be paying for breastfeeding mothers, just like they do with WIC. There should be some piece in there to cover that. For the first 6 months minimum, as we know that the Pediatric Academy has said that babies should be breastfed exclusively for the first 6 months. So first 6 months coverage, when most problems, by the way, happen in the first 6 months. So that would be something we could look at around policy, is my recommendation.
Well, thank you. And let me just ask Dr. Crear-Perry and Dr. Barfield if you have a quick thought. Joia?
Yeah, so we know IVCLCs are really important, as Shafia just said, and the hospitals usually have funding to support coverage. So wherever, if you're in Connecticut, the system there should, but as Shafia mentioned, it should be a policy. So the state should be able to provide you with ongoing support that you don't have to ask for one-offs to support the community, but the state should be funding that. And hopefully CDC has some funds as well. Dr. Barfield.
So, our division of physical activity, nutrition, and obesity does a lot of exceptional work in breastfeeding and is really trying to make this a reality for everyone. I appreciate, the question and particularly really the importance in terms of understanding early initiation and continuation of breastfeeding, and that mother's milk is the best medicine for infants. And that in my specialty of taking care of preterm infants, we have to think about also the coverage and availability of mother's milk as a way to help and treat babies, as well as helping educate mothers in terms of the importance of breast milk as a nutritional, and again, the all of the many factors we know is really beneficial.
Look, I always say this, that, and when we're having a discussion like we are today on such an important subject, I would really like to reconvene everybody in a few years and say, okay, have we made progress in the right direction, or have we fallen back? What have we learned in that process? And you guys you all have helped me so much understand a lot more of the terrain of this topic, and very grateful for that. Shafia Monroe, president of Shafia Monroe Consulting and Birthing Change. Joia Crear-Perry, president and founder of the National Birth Equity Collaborative. And Wanda Barfield, director of the Division of Reproductive Health at the Centers for Disease Control. Thank you so much. Really, really appreciate it.
Thank you. My pleasure.
Well, that brings us to the end of our program today. A big thank you to March of Dimes for its support and all of you attendees. For any of you who missed these conversations, and they're great conversations this afternoon, we will have the video up from the event on our website shortly. I'm Steve Clemons. Be well.